Hello, everybody. Welcome to this podcast, which is a part of IIP Pune's initiative on World Kidney Day. Today, we will discuss in brief causes, management, complications of a very common condition in children, urinary tract infection. We have renowned pediatric nephrologists from Pune as part of the eminent faculty with us to guide us. Dr. Manoj Matnani, Dr. Suprita Kalra, and Dr. Puneet Chajed. Moderating the session will be Dr. Vinod Chelar and Dr. Keyur Mahajan. Over to you.
So with this brief introduction, let us start with today's session. So first question is to you, Dr. Manoj. What is World Kidney Day and when is it celebrated and what is the theme for this year?
Okay, so World Kidney Day is celebrated worldwide. It is one of the initiatives of our international society. It is called International Society of Nephrology, of which nephrologists, adult nephrologists, and even we pediatric nephrologists are a part of it. So it is celebrated once a year in the month of March, and it is usually every second Thursday. So it's this Thursday, which is 13th of March this year. Okay. And every year there's a specific theme which is picked up for the World Kidney Day, so as to raise kidney awareness about, because kidney diseases are very silent, and people, or rather children, since we are as pediatricians we are speaking about children also come to us very late with CKD features, advanced CKD, chronic kidney disease, and then we really have not many options except for dialysis and transplant. So the theme which is picked up for World Kidney Day this year is, as you had asked me, that 2025, it says that are your kidneys okay? That's the first thing mentioned. For that we need to do some tests, obviously. And second is protect them, detect early whatever disease it is, and try to protect your kidney from getting damaged. So that's the theme for this year. And a big thanks to the Indian Academy of Pediatrics, because we are doing this session more specifically focused on UTI today. And I think UTI is the most important thing which can be prevented, so as to prevent chronic kidney disease in future in children. So that's the theme for WKD, World Kidney Day this year.
So now starting with the discussion of UTI, Dr. Suprita Madam, what is actually UTI?
So, urinary tract infection, as the word mentions, is an infection of the child's kidneys, ureter or bladder, or the urethra, and sometimes all together. But it is one of the most common causes of fever without focus in young children and one of the most serious bacterial infections in children. And as we will go through this podcast, we realize that there are many ways in which either they are misdiagnosed or the diagnosis is missed in the beginning when UTI was there. But to simply put it, to diagnose, we must have symptoms, and the most common symptom in a child, especially a young infant, will be fever. So without high-grade fever, generally we would not like to diagnose UTI in young children. Adolescents and older people may have very local symptoms of the urinary tract in form of dysuria, and it is diagnosed on basis of a urine routine examination showing more than 10 WBCs on a fresh sample or more than 5 on a centrifuge sample. However, urine culture is the gold standard, and we would like to emphasize that all pediatricians should send a urine culture before starting antibiotics when UTI is suspected.
That is very important.
Yes, you may start when you are thinking of UTI, but remember to send samples first. We need not wait for the culture because it will take its own time.
There is no hurry to start antibiotics.
Yes.
Send urine culture first if it will.
Yes, but definitely if the child is sick and you don't want to wait, so just like we send TLC and we send other workup for fever, remember to send urinary samples and then start treatment as you deem appropriate.
Next question is to you, Dr. Puneet. When should I suspect UTI in a child with fever in my OPD?
So, any fever without a focus should raise concerns about a urinary tract infection. There are specific symptoms that you can find in as age appropriate. Like if it's a baby less than 2 months, you may have lethargy, difficulty feeding, poor weight gain. Even jaundice in neonates could be, prolonged jaundice can be a pointer towards UTI. Then in addition to that, you may have lower urinary tract symptoms like dysuria. You can have frequency of micturition. There can be hematuria. These are the pointers towards a urinary tract infection, and that is when we should be thinking of a UTI and investigating further.
Dr. Manoj, I want to ask you, when a child comes to our OPD with first episode of UTI, how we should investigate this child?
Right, so as Suprita has already alluded that we do a urine routine microscopy, a centrifuge sample more than 5 to 10 pus cells per high power field. Obviously, before starting antibiotics, a urine culture. Very importantly, when we are doing a urine culture, what in our practice we see that urine cultures are taken without giving any instructions to the parents. So I think it is very important to tell them, if it is a toilet trained kid more than 2.5, 3 years, it is good that we can do a midstream sample and also a clean catch, whereby I need to tell you all, because it's important to tell the parents that to wash the genitals first with soap and water, not with any antiseptics like betadine, because they are very corrosive to the sensitive genital mucosa. So we do a clean catch, that is cleaning with soap and water, and then give a midstream. But obviously in younger kids, infants and toddlers who are not toilet trained, in those kids then we have to do basically a urine culture, which is a catheterized specimen. We call it in and out. Put the catheter in, take a sample and out. And it's very easy to catheterize female kids, maybe a little bit challenging in male kids because of the whatever reasons, which male urethras are difficult to manipulate. So that is the catheterized specimen. And third is for very young kids, if you want to skip urine culture, it's fine. But if you want to do, it should be a suprapubic method specimen. So just again, the bladder should be full. Put a suprapubic needle, take a sample, maybe even a few drops, 1 ml is also fine. So urine culture is important because it can help you to guide your management if your child is not responding to your first line therapy. And first episode of UTI, any age, 0 to 18 years, most important is an ultrasound KUB. We say KUB, kidney, ureter, bladder. Usually we say we see pediatricians writing ultrasound abdomen. Abdomen is fine if you want to do, but what happens, the sonologist is carried away by other things in the abdomen. What we want to stress specifically is on the kidney, ureter and the bladder. And specifically what we do is we look at a few things. From the kidney point, we look at the size, echogenicity. It tells you a lot whether there is any underlying CACUT. CACUT is congenital anomalies of kidney and urinary tract. Then we look at the renal pelvis, that is the AP diameter of the renal pelvis, whether it is enlarged or not, to give you an idea whether there is hydronephrosis. Then you come to ureteric dilatation, which is an indirect evidence of whether there is reflux or not. But a catch here is, if the ultrasound scan is normal, it doesn't rule out VUR, because whenever we speak about UTIs, VUR always comes in the picture. And many people feel, oh, ultrasounds are normal, so VUR is ruled out. No, VUR, the gold standard test is micturating cystourethropy. That I'll speak about it later. So I was speaking about the ureteric things. Next is the bladder. For bladder, we need two important things in kids. Doing ultrasound scan, the sonologist really takes a long time with the patient, because the neonate and the infants are very uncooperative. So if we want bladder details, they have to be there 1 hour. The bladder needs to be full. So we need to basically know two things: bladder wall thickness and post-void residue. These indirectly tell me whether there is any infravesical, that is any obstruction below the bladder. So if there is any obstruction, particularly in a male child, like posterior urethral valves, which is the commonest CACUT which we see in male kids. So in that case, the post-void residue, the child will not be able to empty the bladder. So there will be a lot of urine in the bladder remaining. And since it is long-standing obstruction, so the bladder will overwork. So the bladder wall will be thick. So any bladder wall thickness more than 2 millimeter is significant. So the basic ultrasound scan by a sonologist will help us a lot. And then we can ramify. We start the treatment of the patient, and then we decide when to do, which I'll speak later, I think, as in the podcast, when to do a micturating cystourethropy, that's MCU, and DMSA, which sometimes people just write at the first episode. So we'll cover that later. Yeah. So this is the brief investigations: urine routine, urine culture properly done, and a basic ultrasound KUB of the tract.
Yes. One question regarding urine collection. In very small babies, sometimes we use those urine collection bags. So is it appropriate?
Urine collection bags is very appropriate for collecting for doing urine routines, but not for cultures, because all these bags are already contaminated. And whenever you do a urine culture from a bag specimen, you get mixed growth, and that mixed growth is nothing but contamination. So urine cultures from bag specimens, no. But for microscopy, you can use it, not for bag specimens.
Okay, so this next question is to you, Dr. Suprita. Which patients should not be labeled as UTI, and what is asymptomatic bacteriuria?
Just to add on that, many patients come with isolated burning micturition, isolated increased frequency of urine. So does this qualify UTI? Please mention that also.
So, yes, like already said, that UTI in children will not present with local symptoms most of the time. So, if it is isolated dysuria, that means child is having some pain or burning while passing urine, it may be related to a local cause. So, we must look at the in girl children vulva of the child, or in males, if is there any balanitis, is there a phimosis, is there vulval adhesions. So, local examination of the genitalia. Then there may be other local factors like, pinworm infestation. So, perirectal, perianal, and all the perivulval area in a child may be having induration and excoriation because of pinworm infestation. Then, secondly, very tight undergarments, or poor local hygiene. All these causes can lead to dysuria or burning micturition without actually there being a urinary tract infection. Then, secondly, there is always a component of, when we say asymptomatic bacteriuria, we like to say that why was this sample sent anyways? Because the word says asymptomatic. So, the first thing that we need to emphasize is that we should not send samples when we don't know what we are looking for. So, if child truly has symptoms suggestive of a urinary tract infection, including fever and or local symptoms, then only samples should be sent. Sometimes when they are sent for evaluation of fever, so any fever can have few WBCs in the urine, but we need to correlate. So, I'm talking like a lab person when they write correlate clinically, but we need to look at the child in totality, and they may have signs and symptoms of something else. Then there are conditions like Dr. Manoj has already talked about posterior urethral valves or a bladder outlet obstruction in boys, and neurogenic bladder in both girls and boys. So these children may have some asymptomatic bacteriuria. Whenever their samples are sent, the urine routine may show some WBCs and culture may grow something. So again, in these children, we must make up our minds that are we going to treat that if it comes positive? Do they really require treatment? So I think that is a question best left to the pediatric nephrologist. But we must remember that all these need not be treated, and there may be an alternate explanation to why we are getting these WBCs. And if there are suggestions to say that kidney is involved in maybe an interstitial nephritis or not really a pyelonephritis, which will be part of UTI, but interstitial nephritis, again that will have some WBCs. So we must look again go back to seeing the other things in the urine routine examination. Is it WBCs alone? Is it with RBCs? Is there an alternate explanation? Is there hypertension, oliguria? So are we talking of some glomerular involvement also, not just the tract?
Sure. Thank you.
This is a common practice that once you have treated a UTI in a child, we generally want to see what the urine routine and the culture is showing after treatment. So this is a practice which is not indicated. Once you have treated an episode of UTI, there is symptom improvement, there is clinical improvement, there is no role for repeating urine cultures to assess whether the treatment has worked or not.
So clinical response is more than enough adequate to guide you for the treatment.
So we should not repeat urine routine also.
Not needed actually.
Okay. Great. Good.
Dr. Puneet, what primary treatment I should start whenever a child with suspected UTI comes in OPD? And we want to also know that does this treatment differs according to age?
Definitely. The treatment differs based on two things. One is the age of the child, and second is how sick the child is. So if you have a baby who is less than 2 months old and you're suspecting urine infection, this baby needs IV treatment, not oral antibiotics. Again, if the child is very sick, then you need IV antibiotics to start with and not oral. And the third scenario where you need IV management is when the child is continuously vomiting and not able to hold on to whatever oral medications you're giving. For all other cases, oral antibiotics suffice. Now coming to what choice of antibiotics. So it again depends on, is it a complicated UTI where you have systemic features, or it's just a cystitis. Cystitis is more common in the adolescent age groups, which can be easily treated for a duration of 3 to 5 days with first generation cephalosporins like cefadroxil, cephalexin. When it comes to UTI with systemic features, I would start with third generation cephalosporins as cefixime or acoamoxiclav. Having said that, if you decide to start IV treatment for a kid, the first choice would be IV third generation cephalosporin ceftriaxone, and then wait for the culture results. A point to stress here is watch again for clinical improvement. If you have a culture which is resistant to ceftriaxone but the child has improved, you can definitely carry on with your same line of management and need not change as per the sensitivity pattern, because there's difference between in vitro and in vivo sensitivity. So the point to drive home is look at the clinical improvement. And the recent guidelines suggest that you can start oral antibiotics in any cases. There is no proven difference between IV and oral except for the 3 scenarios that I mentioned. There is no change in response to IV or oral. And this is the presumptive treatment that we are talking about before we are getting the urine cultures. If there is no response, if the child has not responded, the symptoms persist or worsen, then we have to change as per the sensitivity pattern.
And one more thing, if I can add here, is more important is it's like a meme or something, one-liner, that don't treat the culture report, treat the child. Because if the child is clinically doing well and you get all sorts of funny organisms, and sometimes we feel the organisms, we don't even know them, they are very, very rare, very rarely that happens, and then the sensitivity patterns are only sensitive to all the hi-fi, meropenem and tigecycline, but the child is doing very well. So we don't need to really look at there and blindly look at that and change the antibiotics. So treat the child, not the urine culture report. That's
right. Now this is a very important question to you, Dr. Manoj, and it is about counseling. Usually parents ask how my child got this infection. How should we counsel them?
Yeah, so again, age-wise, I'll just initially start, as Puneet said, about adolescent kids, school-going girls particularly. See, it's very difficult in India because in the schools where they go, the girls particularly, they don't want to use the washrooms because they are dirty. And many actually parents feel that our children don't want to use it because it's dirty. And if they go and sit on the potty seat, they'll get some infection through the skin and all that. So that doesn't cause urine infections at all. We have to tell the parents bad potty seats or even dirty bathrooms are not the cause of UTI. It's not an infection which is transmitted through the nose or something by sniffing or even touch. More important is a poor water intake. So we have to stress on hydrotherapy. They really have to have a liberal water intake so that they flush out all the bacteria in the urine if they are drinking more. And we just don't have to tell them jada pani piyo. We just have to tell them how much to drink, and it varies according to the age and weight. So I would rather say that if it is a 10 kilo child, so anything maintenance 100 ml per kg, so 1 liter for a 10 kilo should be fine in that way, just an average thing. So anything maintenance 100 ml per kg per day. And hydrotherapy, which we normally say for stones, that's a different ball game, that is 3 liter per meter square, but I won't go in that details. But give them a target that the child needs to drink, because just don't tell them that they should keep drinking. And again, specify that this drinking is all the natural drinks, for example limbu sarbat, narar pani, all those, coconut water, lime water, because otherwise they'll start and drink a lot of juices, sugary drinks, which is not very good. The obesity pandemic is because of that. And also they will go and drink colas, carbonated drinks. So hydrotherapy, specify it is more of the watery and natural drinks. Second important thing is constipation, which is a very important risk factor, which will be covered I think soon later in bowel bladder dysfunction, that the children don't need to be constipated. So make sure that they're having enough roughage, enough fiber in the diet. I think we as pediatric nephrologists, at least that's what I do, I have to sit with the parents, ask a 24-hour dietary recall, what is the diet the child is having. And we see there's a lot of junk, lot of maida, processed foods going on, no fiber going on. So you have to really sit with them, tell them oats, green leafy vegetables, salads and lot of fruits. So constipation is a number one important factor which is to prevent UTI. So a high water intake, high fiber intake, avoiding constipation, and making sure, very important here, that we call it urotherapy, which is you have a timed voiding and timed drinking. So they should not be postponing their voiding, particularly adolescent girls. As I said, bathrooms are not clean, so they just don't want to use it. So they don't want to stimulate their bladder, which means they don't want to drink. So you have to tell them you have to drink whatever you drink in a day. At least go once or twice to the loo, go and pass urine over there, whatever the circumstance may be, because that doesn't cause UTI. But your avoiding postponement will cause more urinary retention, and more commensal bacteria may become pathogenic because of you not voiding in on time. So these are a few things which we need to counsel the parents for preventing UTI, and why UTI had happened in the first instance. This will tell them that.
Dr. Kala, madam, we want to know what advice ideally we should give to parents to prevent future infections.
Yes, just to continue what Dr. Manoj was saying about voiding postponement, it is also seen in younger children, the preschoolers and who have just joined school, because now they are very much into, it's increasing. They very much want to play a game on the mobile, a cartoon that they want to finish. So the child is holding on to the urine, not going to the washroom, and it gets aggravated if this child is also constipated. So so they will have a both bladder and bowel postponement, and then the child may sometimes rush to the washroom and have urgency and urge incontinence, which sometimes gets labeled as UTI because child was otherwise dry. Child had achieved being dry, and now because of this he has sometimes daytime urgency, urge incontinence, and parents feel that is it because an infection has happened. So coming on to how to prevent a future. So once a child has had a urinary tract infection, so whatever preventive measures that Dr. Manoj was already talking, they become even more important. So same I would like to say, water intake, very important. So we need to give them a target, and we also need parents to lead by example, that the diet and the water intake of the whole family should be like that. The child should not feel that only he or she has to change the diet and the rest of the family or the other siblings can continue to eat pizza and Maggie, but I cannot because I fell ill. So we must emphasize that it is the normal healthy diet. It is not something that particularly has to be done for urinary tract infection. But that normal healthy diet, which includes seasonal fruits, vegetables, which are a very good source of not only roughage but other minerals and vitamins that the child needs. So all this will help prevent UTIs. And then we must also tell them that, again, that we already were talking about, that constipation needs to be prevented, and all these measures will help in preventing constipation. So herein comes the concept of bladder bowel dysfunction, that in a child with constipation, we know that both the urinary tract and the bowel, they have common origin in cloaca, as the baby as from the fetal origins, and because of this they have common nerve supply. So if the rectum is loaded with hard stools, constipated stools, then this will definitely stimulate either the bladder to have urgency and passing and incomplete voids, or the child may have such hard stools that he is trying to hold on, not passing those hard stools because he or she knows that it is very painful. So they will also end up holding urine, and then at some point have dribbling and urinary incontinence. So again, preventing or treating the bowel symptoms goes a long way in preventing urinary tract infections. Plus, there is a definite role for antibiotic prophylaxis, but for that, the workup should be complete. And I would suggest that after a urinary tract infection in a young child defined as an infant or a neonate, or a child who's had recurrent UTI in the past with or without bladder bowel dysfunction, the evaluation should be completed by a pediatric nephrologist. They should be referred timely. And these children need to be on antibiotic prophylaxis till an underlying cause is found and addressed adequately. So they should be on follow-up with a pediatric nephrologist at least for this duration, because we know that each febrile UTI, especially if it is involving the upper tract, is a long-term risk factor for renal scarring, and that can carry on to adult complications like hypertension and long-term renal damage. So that is the premise of trying to prevent. It is not just that we are preventing one febrile illness, but also its long-term implications.
I have a few points to add. So parents generally come with, after doing their research on internet, that cranberry juice or cranberry extract can help in preventing UTIs. The juice that you get is just preservative loaded and not contain the active ingredient that is known to prevent UTIs. And to have that active ingredient, you need to have liters and liters of juice in the day. So this is not a very practical suggestion that we should be encouraging in kids, at least, that having cranberries or cranberry juice will prevent further UTI. What points have been mentioned by the eminent faculty here are to be emphasized. What I tell my patients generally is pass urine every 2 to 3 hours. Once you're out of the bathroom, have a glass of water so that you have enough fluid in you and making urine for the next 3 hours.
Okay, coming to next question, and this is for you, Dr. Puneet. What are causes of recurrent UTI?
Yeah, I think as Dr. Suprita and Dr. Manoj has already alluded to, bowel bladder dysfunction is a very, very common scenario and one of the most common reasons for having recurrent UTIs. If untreated and long-standing, it can lead to a secondary vesico-ureteric reflux that can aggravate the problem further. Primary vesico-ureteric reflux is another important cause of recurrent UTIs. And the kids having any obstructive uropathy like a valve or some dysfunctional voiding where they are postponing voiding and they have urinary stasis for a long time in their bladder, this again predisposes to recurrent UTIs. Mind you, one important point that I would like to mention here is diapers are not a cause for UTI. Diapers can lead to UTI if a soiled diaper, like with fecal matter, is left unchanged for hours altogether. That's when we can have some contamination, more so in the girls, less in the boys. But this is a very common question that we get in a clinic practice. Diaper घातल्यामुळे झालं का? The answer is big no. If you change the diapers at regular frequency, that is not a cause of UTI. So recurrent UTIs, when you are faced with recurrent UTIs, think of BBD, bowel bladder dysfunction, think of any anatomical or structural problem in the urinary flow, and third is the functional behavior of the bladder. Is there regular voiding or as timed voiding, as Dr. Manoj Matani already pointed out to. So prevent urinary stasis and adequate hydration. These are the two important things to look for when you are thinking of a recurrent UTI.
Dr. Manoj, we want to know how we should approach a child with recurrent UTI in terms of how we should investigate and how we should manage. Please answer in brief. Thank you.
Right. So taking on to that before I forget, so diapers don't cause UTI, but when you have recurrent UTIs, make sure the children are not on diapers because sometimes the parents, the mother becomes very complacent. हाँ doctor ने एक बार बोला है diapers से नहीं होता है, but that can be an additional risk factor for soiling over there, and particularly if your child is having recurrent UTI with fecal soiling, constipation, all that can add. So recurrent UTI, make sure diapers are not really encouraged, that हाँ घारा and all that. Cotton nappies are good enough. Okay, coming to another big entire gamut of talk. It can be a big talk in one way, but to summarize that, how do you investigate recurrent UTIs? So I was already speaking about urine routine, urine culture, and ultrasound KB. So with this, you'll get to know ultrasound scan will tell you what is happening inside, and many such patients also come with antenatal scans, because that's another thing which we probably didn't cover. Antenatal scans showing some problems, some hydronephrosis, some hydroureter, and the gynecologist tells them, or the sonologist, also anomaly scan person, that this all will disappear disappear as the child, it will resolve as the child grows. No, it doesn't resolve. We have to really serially follow up, and then we see whether it is resolving or not. Though 70-80% of transient hydronephrosis is there, but there are many other things. If there is a hydroureter, for example, that is ureteric dilatation, that will never resolve, and that has to be investigated. So looking at common causes, particularly we'll go age wise. So younger kids, if it is posterior urethral valves, boys particularly, they have infravesical, below the bladder they have block valves, and that causes increased bladder pressures and secondary VUR. So to diagnose that, the gold standard would be MCU. So we'll speak a little bit about MCUG, that is micturating cystourethropy. So don't shy away, because the initial teachings many years ago when I was a resident and a fellow, we used to wait for MCUs to be done. Maybe the child is discharged, let the UTI be treated, but we never know in India that the child will be lost to follow-up, they'll never come back to you. So very important, if you're suspecting on an ultrasound scan that if there is hydronephrosis and hydroureter, maybe bilateral, if there is there, then you have to do MCU right during the admission. Let the child settle, let the fever settle, and the child will already be on antibiotics. So micturating cystourethropy, we are trying to really go away, because nowadays we see a lot of MCUs are done. So since you're asking me when to do, so MCU should be done during the stay. And for bilateral hydrouretronephrosis in a kid where there will be additional history, the mother would say it's a poor stream of urine, and antenatal scans also will tell you that there was oligohydramnios, bilateral hydrouretronephrosis. So such patients, I think you should directly pick up the phone, your friends, we are available. Pediatric nephrologist needs to pitch in here to decide when to do what. And micturating cystourethropy also should be done in a setup which is expert at doing it, because catheterizing such small kids can be a challenge. So ideally a pediatric surgeon needs to be around, but we really can't blame them. They are all busy with their stuff. So it is good that an expert sonologist should do. The films which should be there should be a pre-film, that is what we call scout film. Then it should be a filling phase film, which will tell you quite a few things about anatomy. Then a voiding phase film, because sometimes we see that voiding film is not there because the valve is picked up during the voiding film, and last is a post void film which will tell you how much is remaining. So I don't want to go in the details of MCU, but MCU, I think, just call us up, because it's a very pediatric nephrology investigation which should be done. Honestly, we are guilty, even we don't have time to go and do it ourselves or be with the sonologist, but I always speak with my sonologist and tell them that I want this, and please write down, specify that you need all the 4 films, because MCU is a very one-time investigation, I feel, and it's a very traumatic for the patient. It's a tiny kid, it will remain in his memory track forever, and we can't do it again and again, so might as well do it properly. And the other thing comes is, because it's scarring and hypertension already has been spoken about, we don't need to worry about scarring at that point of time. Remember, scarring will only happen after a few weeks, and few means around 8 to 12 weeks. So DMSA scan, which is the gold standard to pick up whether the child has scarred the kidneys, that will only happen after around 3 months of treating the UTI. Because sometimes we see, I mean, honestly, I'm not trying to target any pediatrician here, but it is written MCU, DMSA and DTPA, all 3. My God, that is really not indicate. DTPA is absolutely out of the question here. And MCU also we should know when time. And DMSA, acute DMSA you can do, you're welcome to do, but that will only tell you the acute pyelonephritis, and you don't want acute pyelonephritis, you want chronic pyelonephritic scarring to be picked up, which will only happen after 3 months. So I think a recurrent UTI child, it is best that you please involve a pediatric nephrologist from the beginning, because he or she is best capable of knowing what is happening with the child, and we need to pinpoint the cause. Coming to MCUs for small kids, girls, there can be just primary VUR, and again primary VUR, I think it is important not to just jump and immediately do a pediatric surgery referral for ureteric reimplant. No, I think let the pediatric nephrologist decide when a pediatric surgeon wants to be involved, because that is one take home message I feel, because we see we are bypass, it's not that we are feeling hurt or something, but primary VUR also in girl children, we have given away all over the world protocols. Surgery, if you do a surgical ureteric reimplant or a medical treatment conservative, it has been shown that there is no actual difference at all. In the long-term outcome, it's not there. And if the scarring has to develop, the scarring will happen whether it's reimplant or not. Because remember, all these things start antenatally, and all this ureteric bud starts and from the cloaca and mesonephric duct, all those details I don't want to go. But everything, when the ureteric bud induces the mesenchyme and starts the kidney to develop, to form, the kidney architecture is already damaged. So it's what we call a kidney which is dysplastic, which is actually programmed to become bad. So even if you reimplant such kids, which is a big surgery, which surgeons are very happy, हमने reflux निकाल दिया, but you don't know the child will develop CKD soon because the kidney is already fired right from the antenatal period. So let us decide, the pediatric nephrologist, that when to send to a pediatric surgeon for operation. And even nowadays, let me tell you, the pediatric surgery crowd in Pune is fantastic. All of the pediatric surgeons also have come down. They don't do reflux for reimplants. So please make sure that reimplant is not a thing to be done at all. It is the last thing which I would think in a child. So I think these are a few things. Thanks.
So one more. Is there any correlation between the grades of UR and
Yes, there is, yeah.
surgery?
So the lower grades of reflux, which are grade 1, grade 2, they are minor. As the child grows, by age of 5 years, it will resolve spontaneously. Whilst grade 3, 4, 5, when we say grade 3, it starts with ureteric dilatation, and 4 and 5 are ballooning, and the kidney is fully involved in it's more towards the central area of the kidney. So in those cases, there are more risk for scarring, and we need to do DMSA to pick up. And again, one DMSA is good enough to tell you what is the status. Some people just keep doing DMSA karun gya without any indication. There is no need to really do those. So mild VUR 1 and 2, even if you don't send to us, they will by 5 years usually resolve. But I think again, MCU should not be repeated, because that's what I have seen in our practice. Since you asked me, Vinod, that MCU should not be repeated again and again. If the child is doing clinically fine, absolutely no infection, then we just give for prophylaxis, just 1 year prophylaxis. If there is no UTIs for 1 year, we try to stop prophylaxis and see what is happening to the kid. And usually by 5 years, all the mild VURs, 1 and 2 will resolve. Whereas 3 onwards will not resolve. There's something more sinister happening, and we need to be involved earlier. Hypertension, scarring, CKD will happen in such kids. So milder reflux grades can go off. Yeah.
So grade 3, grade 4, grade 5, should we involve pediatric surgeon in these cases?
No, let us decide when to. Sorry for being so.
Let them decide when to involve.
Yeah, because I think I tell this, I mean, with due respect to our surgeons are fantastic. I tell them, kidney doctor ko dekhne do. Surgeons are helping us for plumbing and all that, but it's a kidney doctor who should decide when to do DMSA, when to do DTPA. Because many surgeons also sometimes just write DTPA, DMSA, not needed. So sorry, it's our organ. Let us decide.
When we were
Yeah.
we are doing residency,
Yeah.
and we were told that
Do a-
grade 4 and 5 should go
So
to
that is
pediatric
what the
surgeons for
concept
surgery.
has changed.
It has
That's
really
what Dr.
changed,
Manoj
yeah.
is trying
That's
to
what even
explain.
Vinod and me are same batchmates. That was the teaching 20 years ago, 25 years ago, when we were fellows and residents. No, it has drastically changed. You are very right. Suprita is also saying everything is changed to conservative management of reflux rather than the surgical management. So no surgeons. Sorry for this.
And so, continuing what this has just led us to, that a ureter is just a pipe, we explain to the patients that it is a pipe connecting two major organs, the kidney and the bladder. So it is not a plumber's work, and it is not a passive pipe that you reimplant. It is like a cosmetic correction. But if it was not causing any problem to begin with, let's say it is a high grade reflux which was diagnosed after 1 UTI, grade 4, grade 5. But beyond that, with good conservative management, good preventive measures, child does not have a UTI. Again, no second UTI. And after this first UTI, like Dr. Manoj has already said, 3 months down the line, you did a DMSA which showed no scarring. So there is no point in trying to reimplant this bladder, one, and there may be no reason why you need to do an MCU to see whether this grade 4, grade 5 has resolved or not, because it is not causing a problem to the child. On the other hand, there may be a child who had a high grade, who had high grade fever as a 3 or 4 month old baby. On evaluation was found to have a culture positive UTI, required IV antibiotics, and later when this baby was referred to a pediatric nephrologist like Dr. Puneet or Dr. Manoj or myself, he was advised a MCU. This MCU showed a grade 4 VUR, and the baby was put on prophylaxis. This is what we do generally. And later on prophylaxis, this baby still has breakthrough UTI. When we do DMSA, there is scarring. So I would suggest that we repeat the DMSA after 3 months of the next culture positive UTI. So if this baby is having recurrent UTI which are culture positive, you wait and do a second, a repeat DMSA maybe couple of months later, from the first, because now you are worried that this baby, despite antibiotic prophylaxis, is having a recurrent UTI. So you are planning for a surgical intervention here. So, that is when you would plan that though it is a high grade VUR, this is the one which is causing recurrent febrile UTIs. Similarly, in a single functioning kidney. So, in children with posterior urethral valve or in girls with primary VUR, there may be a condition, there may be a situation which is rare, thankfully, but it is definitely there that on first DMSA, after the culture positive UTI, you realize that only one kidney has good function. The other is either dysplastic or badly scarred even on the first DMSA. So if this baby has recurrent UTI because of reflux on this good kidney, then this will become an indication for early surgery, at least consideration. So like Dr. Manoj was saying, that let the pediatric nephrologist decide whether this child should go for surgery or not. But it is not that we are going to take away all cases from the surgeons. Their definite role is there, but it has to be defined that what is that definite role that we are talking, because after all, we are looking at the benefit of the child, that it should benefit him clinically and also prevent some long-term should prevent long-term complications.
So as she rightly said, I'll add the 3 indications for ureteric reimplant. You can directly send it to them. We don't mind it. Solitary kidney. Second is breakthrough UTIs, whereby there is on chemoprophylaxis. Any of the antibiotic you're changing, it doesn't work, and the child is just getting more and more UTIs, and your DMSA maybe after 6 months is showing that function has started coming down. Then you do ureteric reimplant. And third important is solitary, you said, and if there is a severe VUR, grade 5 VUR, that's what we also were taught, and we have already seen that there is a lot of scarring in the first DMSA, and I mean we already know that the child has CKD, the creatinine is not coming down, there is severe proteinuria, stunting. In that cases, then that is the third indication to directly go for, because somehow or the other we are trying to prevent more and more damage to the remaining nephrons, so they are not fired, so you want to prevent that reflux. And remember, primary reflux per se doesn't cause scarring, it is an infected urine which causes scarring. So very important, and particularly in India, if there is infection again and again happening in a child, for whatever reason we have to evaluate, obviously we'll do that detailed evaluation, but then we think of reimplantation early, then we think of surgery that time.
We've been talking about recurrent UTIs, breakthrough UTIs. What we haven't discussed is active surveillance for a UTI. If you have a kid who has had a UTI in the past or has a structural abnormality which you are very well aware of, any fever in this child without a focus, the first step should be a urine routine. So this is a very important point. We've been talking all through about prevention, everything, antibiotic prophylaxis and surgical management, but active surveillance is as important as all of these interventions.
Dr. Supreet, we already have discussed so much about bowel bladder dysfunction, but considering the gravity of the issue, I would again like you to revisit the same issue. How much bowel bladder dysfunction plays role in recurrent UTI?
So let's say in an older child who's had a UTI first time after 4 to 5 years of age, I would think of bladder bowel dysfunction as the underlying cause of urinary tract infection rather than a underlying congenital anomaly of the kidney and urinary tract, or the VUR or PUV, because we know that most of those children would have presented early. So a child who is a preschooler or just started school presents with urinary tract infection first time around 4-5 years after he should have been toilet trained and he started going to school. This I would like to exclude bowel bladder dysfunction in the first go. And how we exclude is that many times when you first ask, because these children are now toilet trained, so it is not that the mother is supervising every day whether child has passed stools or not. So we ask them to make a diary. We make them consciously aware of and trying to find. They may say in the first go that no, my child does not have constipation. But if you go and dig into the detail, they have not really been seeing. And so they do not know So one thing that their mother will notice is if there is fecal soiling of the undergarments. That indicates encopresis. That indicates usually very severe constipation. The other thing that it may indicate, and we always want to rule out before we label a child as bowel bladder dysfunction or voiding dysfunction, is neurogenic bladder. So again, examination cannot be overemphasized of the spine to say any telltale tuft of hair, sacral dimple, of the lower limbs that increase deep tendon reflexes, because a mild, not mild, I would say a minor, a spinal deformity can be sometimes not picked up. So a diastometamylia, which will not have a tuft of hair or a big meningomyelocele, but still affect the nerve supply to the bladder and bowel. So we need to rule that out. Sometimes even investigations are required. But yes, so we ask, coming back to bowel bladder dysfunction, to definitely take that history from parents. We give them a diary. We ask them to make a chart for next 7 days that you mark whenever the child is passing stools. And Bristol stool chart is also helpful. You show them and say, tell me what type of stool was there when you flushed the toilet. So is it hard pellety stools? That is definitely an indication of constipation. So because when you treat this UTI, to prevent the next UTI, you have to do away with this bowel bladder dysfunction. And we've already talked about that, how to prevent that, with adequate water and fiber rich diet. So to identify this chart of how many times did the child really pass stools in the last 1 week and what was the type of stools, it goes a long way in trying to get definite history of bowel bladder dysfunction.
So we are running out of time. Please be brief. Dr. Puneet, the role of urinary dipsticks in OPD for diagnosing UTI, importance of culture examination and methods of urine sample collection in small children in OPD.
So, urinary dipsticks in the OPD is as important as a stethoscope or a otoscope. Okay, it's a point of care testing and very inexpensive way of detecting a UTI early. As we have seen in the long discussion that we have already having, early treatment prevents kidney scarring. So they have good sensitivity and specificity. If you talk about just leukocyte esterase, it's more specific than sensitive. Likewise for nitrites, it's more specific than sensitive. But when both are used in combination, if you have both positive on a dipstick sample, you can conclusively say that this is a UTI. The specificity goes up to almost 98%, though the sensitivity is less. So you can at least rule in or rule out a diagnosis of urinary tract infection based on your clinic dipstick, and then send cultures and start antibiotics as we discussed. The next point is importance of culture examination. Why do we need to do cultures? We have dipsticks as a tool which can give us rapid diagnosis, but do we still need a culture? The answer is yes. You will come to know what is the bacteria, and what antibiotic sensitivity pattern is going to be helpful, just in case if the child does not respond to your oral management, or child gets sick, or there's a renal abscess or some perinephric collection, something of this. If the child were to complicate, you have nowhere to go if you don't have a urine culture. So that's the importance of having a urine culture. There are various cutoffs about the colony forming units. If it's a midstream clean cat sample, more than 10⁵ in the presence of symptoms is taken as a UTI. If it's a catheterized sample, more than 10⁴ colony forming units per ml is taken as a cutoff. And if it's a suprapubic aspiration, any growth is definitely significant, but they say the colony count should be more than 10⁵. The last part is methods of sample collection in small children. I will cut it short. Toilet train, not toilet train. If toilet train, get a midstream clean cat sample, as Dr. Manoj Matani already pointed out, after perineal hygiene. If it's not a toilet trained children, still go for a midstream sample. Something called as a quick V technique might help. Make the child lay down on a flat surface, use a cold gauze and just run it over the suprapubic area, and that might help to pass urine. The other is, what I tell my patients is, go to the bathroom and put the tap on, that flowing water can initiate a reflex in kids and help you collect a sample. The best time is maybe an hour or 2 hours after a good breastfeed. That's when the yield of the collection would be maximum. And if you're unable to get a midstream sample in a non-toiletering children, then catheterization is the way to go.
Just a quick word. If you said that there are cutoffs for only counts, if my child is symptomatic, clinically I am suspecting UTI, and still the count is 10^3. So, what should we do?
Hands down, the clinical exam and the clinical picture takes precedence over just the numbers on the culture reports, because
and latest guidelines have also mentioned that a symptomatic child who has definite symptoms of high grade fever with urinary symptoms, 10 to power 3 or 10 to power 4 can also be taken as culture positive. You don't necessarily need to reach 10 to power 5 only.
yeah, as previously mentioned, we are treating the child and not the reports.
Not the reports.
And significant pyuria is there, pus cells are there, so it is
Yes,
good enough to
yes,
tell you this.
Culture is also dependent on when and how the sample was transported to the lab and when it was plated. If you've collected a sample in the morning and that has been lying outside at room temperature till the afternoon, there is going to be bacterial overgrowth. So if there is a delay, store it in the refrigerator at 4 degrees Celsius and then you can use it for culture.
Now, this is the last question of today's session, and this is to you, Dr. Manoj. When should we refer a child with UTI to a pediatric nephrologist?
Yeah, so I think it is just to sum up the entire. Yeah, I had already said it quite a few times. Yeah, so to sum it up, any child where you are struggling, he's coming to you recurrent UTIs, please immediately refer. First episode of UTI, if you need some help to decide when to do MCU, when to do DMSA, please just call up. Maybe just on the phone you can maybe do everything. Other thing is, if there is severe grades reflux, as we are saying, they have to be referred immediately. Very important, posterior urethral valve, which is one thing which I will elaborate here. The surgeon does the posterior urethral valve ablation. It is taken care of and everything is rosy. They said even the pediatrician feels good, obstruction cardiac hai. Surgeon also feels good, but we are the most unhappy people on earth because that child has already got dysplastic kidneys. Posterior urethral valves is a disease which will go on forever. It can present even at adolescent with bad bladder issues. Remember, it's an obstruction below the bladder and everything is affected. The bladder is affected. There could be reflux. The kidneys are dysplastic. So these children have a lot of bladder problems which need to be addressed regularly. The in between urodynamics and all that will be done when the child is a bit older. We have to assess that. Then this child will also have dysplasia. So chronic kidney disease will be there, concentrating defects, polyuria, all that big chronic kidney disease gamut will come. So in short, my thing was to prevent chronic kidney disease in any child where you are feeling this child is coming to you for the second time with a urine infection, please immediately feel free to refer.
Okay. Thank you so much, all of you, the excellent faculties for this excellent session. Before concluding, may I ask one line from each of you? One last take-home message for UTI, each of you.
So, keeping in theme with the World Kidney Day, I would say protect their future flow. Take childhood UTIs very seriously.
And just, it's like a meme that fever is not ceftriaxone deficiency. So when you have fever, please suspect UTI when there is no focus and remember to send urine routine examination, culture, do dipsticks in your clinic and then only start antibiotics, especially not third generation cephalosporins at the first go.
So I would say, just to resound, diligent use of antibiotics, and if you want to do cultures, please instruct the parents how to collect a proper not bag specimen, as Vinod already pointed out. Instruct properly how to collect a culture. Thanks.
Thank you.
Thank you so much, all of you. Let us conclude this session.
That was a really informative session. I think everybody is going to learn a lot from this, and it will definitely guide good management of all kinds of urinary tract infections and other kidney conditions in children. Thank you so much, and we really value your time. Thank you.
Thank you. Okay.